what's different is airway clearance technique. But our therapeutic exercise is going to concentrate on what?
First, let's breathe.
So breathing exercises, and what else?
Energy conservation.
So I just said breathing exercises. Energy conservation could be a focus. What else? So aerobic exercise as well. Okay, so key things that are different for pulmonary interventions. Focus on aerobic capacity, like endurance training, energy conservation, breathing exercises, which there's a whole bunch of different ones we're going to go through, and airway clearance techniques. Okay, so another key thing in treating a patient with a pulmonary dysfunction is monitoring physiologic response to exercise. Okay, which means taking all the vitals at rest during exercise and after exercise. And these vitals can be used to show improvement over time in aerobic capacity, which is exactly what your experiment is. Okay, now you may or may not be treating the patient primarily for their respiratory disorder. You may be treating them for something else, and they have a comorbidity of a respiratory disorder. That still means you're going to do all the same monitoring of vitals. Now, if it's the primary reason you're treating them, they could come in because they get short of breath upon exertion. That could be the primary reason you're treating them. So during a subjective interview, what sort of questions are you going to ask them? How's your breathing? How can we make that more specific?
Are you able to take deep inhales and exhale deeply?
Okay, so maybe the depth of breath. Can they take deep breaths? What else can we ask about their breathing?
What activities make you short of breath?
Okay, specifically what activities bring on their shortness of breath? Is it walking to and from the restroom? Do they have to walk all the way around the block? Is it when they walk from the car to their door? So getting an idea of distance, time, and intensity. What else can we ask about their breath? Yes?
The environment where they live, because they could be next to a factory where there's no,
Environmental.
So environment is important because we want to know if there's any irritants or allergens. What type of weather
Pollen.
do asthmatics not like?
Cold.
Cold and dry. So if they're asking you, well, what time of day should I go for my daily walk? You're going to say not in the morning because that's when it's cold.
Like that. Noon.
Yeah, so later in the day when it's warmer. Okay, what else?
Position.
Position.
Such a little woman, dude. Did you bring this today?
Remember, there can be a difference between challenging the patient and helping the patient. Again, recovery versus compensation. Does anyone know if someone with a progressed COPD is having difficulty catching their breath, what position should we recommend that they go into?
30.
Seated, but we're going to adjust it a little bit. Well, okay, let's think of it this way first. If someone's having difficulty catching their breath, what position will make it harder?
Supine.
Supine, flat on their back. So what will make it easier? Bent over, or flexion, and what? Everyone take your arms,
Ah.
put them on the desk, lean over.
Plantar grid.
Well,
Left
so
foot.
not plantar, but they have to have upper extremities supported in some way. Because what does that deload? Shoulders, what muscles are in the shoulders? The accessory breathing muscles. So if they're having difficulty catching their breath, you actually want them to use their accessory muscles to help them catch their breath. It's a matter of catching their breath. But then, when they're not in an emergent state, you would want to challenge them and challenge them to use their diaphragm more than their accessory breathing muscles. Okay, but if someone's having difficulty catching their breath, you instruct them to bend over and have upper extremities supported. In order to deload the accessory muscles so they can use those for catching their breath. Okay, anything else we can ask about subjective-wise if their primary concern is shortness of breath?
Pain? Does it hurt? Pain reading? No.
If there's pain associated with the shortness of breath, that could be a possibility, not likely. How long does it take to recover once they do become short of breath? Are there any techniques that they've learned or started to use to recover?
Makes it feel worse. It makes it feel better.
Yeah, ags and eases. What aggravates their symptoms, what eases their symptoms. Do they have a cough? Is it productive? Okay, so we've taken vitals. What sort of things are we going to look for upon observation? Treating someone with a pulmonary disorder, whether it's primary or comorbidity. Okay, chest excursion and symmetry. We may be able to just start observing it before we actually measure it. Are they using the left side of their lungs more than the right side? You can actually teach segmental breathing. Do they have a barrel chest? What else are we looking for? Okay, at rest, what is their breathing status? Do they just be at rest? What else?
Digital clubbing.
Do they have digital clubbing? What else?
36.
Cyanosis.
Expansion excursion.
Who said that?
Okay.
Uh-oh.
Louder, Karen.
What else? Facial expression. What about posture? Does posture matter with breathing?
Yeah.
Oh, yeah.
Not sure.
Are they underweight? Maybe we need to recommend that they go to a nutritionist. Okay, so when prescribing aerobic exercise, which again, you're prescribing it to yourself during your experiment, you're also going to do this on Tuesday. You're always considering the mode, so what type of exercise are they doing? Are they going to be walking? Are they going to be walking on a treadmill? Are they going to be running? Are they going to be swimming, biking, elliptical? Intensity, which you're going to measure with target heart rate with the Carbonin equation that I wrote out earlier. Or no, I didn't write out earlier. It's written out in your experiment. Your duration and then frequency as well. Okay, so we just talked about aerobic exercise that we're going to be prescribing for our patients. If someone is deconditioned, what percent of maximum heart rate are we going to recommend that they begin exercising at? 40 to 50. Okay, and we can also determine intensity through rate of perceived exertion. So we may have to determine intensity based on at what intensity do they become short of breath and exercise at just below that intensity. Okay, we may also have a flexibility program. So what part of the body do we need to be most flexible to improve respiratory function? Thoracic spine. But we can't forget about the lumbar spine because that relates to diaphragmatic control. So if you have increased lumbar spine flexion range of motion, you'll have better diaphragmatic control. Excessive lumbar hyperextension is associated with poor diaphragm contraction. So we want a neutral lumbar spine and lots of thoracic extension mobility because we don't want the excessive kyphosis. And we have to also make sure that the costovertebral joints are mobile so that the ribs can actually move, as you assessed yesterday. Okay, strengthening should be focused on postural control and diaphragmatic contraction. How do you challenge the strength of the diaphragm? Okay, so first up, if you're educating someone on diaphragmatic breathing, what do you tell them to do with their hands? Belly. And you can do 1 and 1. Don't move here, move here. And what do you want to happen to the belly upon inspiration?
The belly goes out.
Fill it with air, expiration, go back down. And you don't want the chest to move. Okay, so they've gotten the pattern down where they can inflate the belly. Now how do we challenge the strength of the diaphragm? Resistance. How do we add resistance?
Push. Empuje.
You can actually put a weight on the belly.
Cup weight.
Start light, but you can add weight.
Cup of coffee.
Now, forceful expiration will not work on the diaphragm. Remember, the diaphragm only contracts upon inhalation, inspiration.
Valsalva.
Don't want Valsalva. That will just spike up their blood pressure, and they already have a pulmonary issue, which is closely related to cardiac issues.
When we educate like children in these techniques, you know how we have to make it fun. So can we combine that with like music?
Yeah, because timing is important too. You don't want the breath to be too quick, so you want a slow inhalation and a slow exhalation. So adding music is a great idea. Okay. Okay, let's talk about postural drainage. So postural drainage and airway clearance techniques are necessary whenever someone has excessive mucus production. So what are some diagnoses where postural drainage will be necessary?
Cystic fibrosis.
Cystic fibrosis, potentially what else? COPD, remember they have a chronic productive cough. And they also have increased risk of developing respiratory infections. So we may also need to educate them on postural drainage or airway clearance techniques. Okay, so postural drainage is specifically using body position to promote outward flow of bronchial secretions. Yes, it's a lovely, lovely thought. Now, in your PT review book, the positions are on page 240, 241. However, I don't think these are that clear, which is why I'm going to send you the other chart. Now, the key thing about, because you're gonna get lots of board questions on this, about they'll name a lobe of the lung, and then ask what position you're gonna put the patient in. And it's not always obvious. So what you have to think about is, you have, I'm a terrible artist, but the bronchial tree, and then lung tissue outside of it. That's one lung. You want all mucus to go to this center bronchial tree.
So it has a chance.
Okay, so you're not thinking about, I want the mucus to head to the mouth.
Right.
You're thinking, I want the mucus to head to this center pathway system. So you have to position the patient that this part of the lung is higher up relative to the center of the person.
Percussion vibration from below. So we'd be doing more.
Yes, but then we have to figure out, is it prone, is it supine, is it sideline, that sort of thing. Okay, so I'll talk you through a few examples.
Bilateral.
Okay, but think of it this way and it'll make it easier. You want it to come to the center so that it can then get into the main bronchi to then come out the trachea. Okay, so for example, you have a few different upper lobes. First one is called the apical segment. You want to know what the apex is? Top, the uppermost. Everyone point to where the top of your lungs are. It's a little bit more posterior.
Oh.
The very top of your lungs is kind of like right where your posterior upper tracts are.
Seems high.
Okay, so if I want these to be highest relative to the center, how am I going to change my position?
Slight forward flexion.
Slight forward flexion. Now they're the highest. Okay, so patient leans back and then slouches forward.
Why would it be the highest if you're just sitting straight?
Because they're slightly posterior. Okay, now you also have upper lobes posterior segment, which is a little bit more posterior. So what are you going to do? Slouch over more. Okay, so you can't really see, but the patient is just slouched over on a pillow. Okay, then you have upper lobes anterior segments. Okay, so we have the apex, posterior, anterior. So if I want this right here to be highest relative to the center, how am I going to go?
Get into the left.
Yeah, just straight supine. It'll make more sense once you have this. Okay, so if you don't quite get it yet, that's fine. But basically they highlight the section in black, and then they show you what the bronchial tree would look like. That's why I like this one better. Okay. Everyone point to your right middle lobe. How am I going to get this part of my body highest relative to the center bronchial tree?
Left sideline.
Sideline. And slightly dependent. So slightly what we call head down, which is called what? Trendelenburg. Okay, and we'll go through these more in lab, I believe, tomorrow as well. Now, the important part about postural drainage is there are a lot of precautions and contraindications. So know these. The number one is congestive heart failure. And the contraindication is Trendelenburg. If someone has congestive heart failure, never, ever, ever put them in the head down position, because you'll essentially internally suffocate them. They have pulmonary edema. Okay, and so, but you don't have to understand why until next week. for now, just know postural drainage is contraindicated for someone, or postural drainage in a head-down Trendelenburg position specifically is contraindicated for someone with congestive heart failure because they have pulmonary edema. So if someone has pulmonary edema for any other reason, you're also not going to put them in a Trendelenburg position. If you put a patient in that position and their shortness of breath worsens, don't do it. That one should be obvious. Again, if there's any other conditions that are made worse by the position, don't do it. Yes, June.
So each position you're gonna stay for a certain amount of time?
You're going to stay in that position, and then the therapist, they may just hang out in that position for a while. And if it's in treatment, the therapist will perform percussion and vibration, or you will teach the caregiver to do percussion and vibration, which are two different manual techniques to help loosen up the mucus. However, make a cup with your hand. We'll do this in lab tomorrow. And tap your chest. Sound a little bit hollow. That's percussion. Now, same position, maintain contact, and vibrate. Vibration. And we'll practice material tomorrow. You perform those techniques in these positions. And again, teach the caregiver to do it because they likely need it to happen more often than they are in therapy. Okay, now after you put them in this position, you perform a percussion and vibration. You then will teach them specific airway clearance or breathing techniques to excrete the mucus. And that's what we're going to talk about next. Okay, so you put them in the position, you've performed your percussion and vibration, now they have to actively use their breath as the last step to get the mucus out. Okay, so this slide is a little bit wordy and confusing. It's actually broken down a little bit clearer again in your PTA review book on page 238. Okay, so we're going to review two different airway clearance techniques. The first one is called active cycle of breathing, and the second is directed coughing and huffing. Okay, so we're going to talk about two different airway clearance techniques. First one titled active cycle of breathing, second one titled directed coughing and huffing. Okay, now the active cycle of breathing techniques there's three different techniques involved. Okay, so this title has three different subcategories, three different specifications. Try to look less thrilled, Ron. Okay, first one is breathing control. Okay, so what you're going to teach the patient to do is gentle, relaxed breathing. Focused on diaphragmatic control. So basically just